Sorry if we late. We come to the last session, the first day of our conference. It is a panel case discussion of HCC cases. Those cases are managed by our multidisciplinary hepatoma group at Ain Shams University, and we have a decision of treatment for each case. And as we see from the lectures, sometimes we have a gray zone in local regional management of HCC or on the treatment of HCC, where there is overlap of the decision and the modalities, and it depends upon the difference in the experience and the school. And this is the rationale of this session, to expose our experience and to show the experience of different schools from the Egypt and from outside. This is first case, male patient, 52 years old, clinically no ascites, spleen, or signs of encephalopathy, and those are laboratory investigation. The platelets are 100,010. The alpha-fetoprotein is 56. This is the relevant data. And the upper endoscopy shows mild antral gastritis.
But then when they progress, they have about 5 options that they could get. They get DEBTase, Y90, repeat ablation, transplant, resection. That's fine. These are all post-progression things that the patient could get. And then when they progress from there, they can now get another variety of 4 or 5 clinical treatments, as you know, because we're going to individualize patient care. And then if you continue along that line, they progress, this is what you're left with. When you're looking at a 100-patient cohort, there's about 25 different combinations of permutations of treatments that person could get. And that's why survival studies in early disease, HCC and intermediate, are very complicated because of post-progression therapy. And the randomization does not necessarily deal with all of these issues. So it's very complicated when you say you read an RFA paper and they talk about survival outcome, because you know those patients got all sorts of other treatments down the line. So again, very, very complicated. So to conclude, I think Y90 is now thoroughly studied and consistently reproduced in multiple settings. I think Y90 is it's a very versatile application where you can do dose escalation, you can do dose fractionation, and because of this versatility, you can look at it at multiple BCLC stages. BCLC-A, where you can do radiation segmentectomy and lobectomy. BCLC-B, where we have the same survival as chemoembolization, but much longer TTP, very important, better quality of life. And very dramatic outcomes on PVT. You can now potentially downstage some people and resect some patients. There are several ongoing randomized clinical trials, but I suspect the survival studies are going to be confounded by crossover. And now our premier data that was supposed to go to 100 patients stopped at 45. Very compelling outcome, level 1 evidence, small sample size that shows dramatic TTP improvement. So we now have some level 1 evidence that shows that at least from a TTP standpoint, which is the correct endpoint in randomized phase 2s, that we have a positive trial showing Y90 outperforms chemoembolization. Thank you for your attention.
So, Salim, that was wonderful, giving a feedback for portal in thrombus and others with not this approach. I might have one question for one person.
Thank you very much, Professor Riyad, for this highly elegant presentation and recent topic in our field. Now we are discussing the issue of we are in country with limited resources and YouTube is very expensive. So can we compensate or alternate this radio embolization by the use of the new era of radiotherapy like conformal or IMRT to get the same result, or is something not compensated?
So I get that question, as you can imagine, a lot. When you're asked about the cost of the therapy, which is high, the implication, of course, is that all of the other therapies are not expensive. I was here all morning and I heard all types of different therapies for colon cancer and radiotherapy that I believe are also quite costly. So I think a lot of the therapies that we're advocating and talking about are costly. I do understand that it is potentially more costly than some of the other immunotherapies, but cost analyses, with these kinds of studies have to do with the benefit you get from time to progression. Chemoembolization patients get 3, 4, 5 treatments. The average radioembolization patient gets 1 treatment. So a true cost analysis has to include an intention to treat approach, a lifelong cost, not 1 versus 1, because many of our patients with chemoembolization get 3, 4, 5 treatments, and I've showed you several. I think every case I showed today, the patient had 1 treatment. So yes, there may be a higher upfront cost. Quality of life is very important. I think a lot of things that we heard today had to do with quality of life and toxicity. So I think the decision when you are implementing something like this, which again, I understand is expensive as a one-off, there are a lot of downstream potential benefits. The ability to resect someone. If you were telling me that I'm not resectable because I have a small FLR, but with 1 Y90 treatment, I might be cured by a surgeon with 1 treatment, this is a cost I would want to think about. And so I think there are a lot of ways to look at this, and to be fair, you have to look at all types of other therapies. As I understand it, the drugs are not very cheap, yet they are applied. The targeted therapies are not cheap. And so everything I think is very expensive. And I understand, but I think, to be fair, we should share the criticism.
It's not a matter of cost, only efficacy of the treatment.
Yes.
Do you think that
Yeah. So I think with Premier, I think that answers the question. The TTP is significantly longer, 26 months versus 6. So to me, that is quite compelling, and the hazard ratio is compelling with only 45 patients. So I think when you have people that have done radioembolization, chemoembolization, they will observe that in fact the radioembolization response is much higher than it takes.
Thank you very much. One American said that I think it's very nice, very cleverly. Well, I'm honored to introduce Professor Gassi for his second talk, and I'd like to ask him to try to come to his home country more than once a year. It's not enough. We really want to collaborate with you. He's going now to answer a very important question. How can we tailor treatment for HCC patients?
Thank you again, Dr. So I promise this is the last time you're going to have to deal with me tonight. So this is a talk I was asked to present today. I was given 20 minutes to go through this. So I thought about a different approach, to look into it in a real kind of cases, scenarios where we have to face specific status of the tumor and the liver cirrhosis. So I took a different approach this time to look at it at 2 different diseases. So on the left-hand side, we have HCC with cirrhosis, which is the majority of cases. So that's a 2-disease state. Survival here is affected by the status of the liver cirrhosis as much as it is affected by the tumor status itself. On the right-hand side, you have HCC without cirrhosis, in which case resection is the curative option. So we're going to start with the case scenario on the right side and dissect it, and then go back to the left side. So we talked about what we currently have available, so I'm going to skip that, and then move right ahead to HCC without cirrhosis. So here, you really want to be able to tailor your therapy to focus on neoadjuvant approach. So if you have a patient with preserved liver function status, type PUA, the liver doesn't look very shrunk on the scan, there is no advanced portal hypertension, you do an EGD, there is no varices. So this is a patient that could potentially be resectable. So the big question here is neoadjuvant therapy. There is unfortunately no standard of care systemic therapy approaches in this setting. All studies, even randomized ones, were negative. So we published recently a combination of chemotherapy drugs for this patient population, 33 patients, and 11 of them made it to surgery. And this is what you really see: is a huge tumor. The liver is completely normal, spleen is not big, so this is a potentially resectable case. The surgeon will tell you if there is any partial response to a point where they can anatomically resect, they will go for it. So this is a patient after 6 cycles. According to our study, about 5 cycles were the median, or the number of cycles needed before rendering them resectable. So we're taking this to the next level and randomizing it to local therapy. So this is for patients without cirrhosis. So moving on, I'm a big believer in Atrium 90, as Dr. Riyad, of course, knows. We're collaborating with him on a project to start a sorafenib Atrium 90 study. So this is a phase 2 study that is running now at MD Anderson, sorafenib plus Atrium 90. The next plan is to have a multi-center randomized study in collaboration with Dr. Riyad, so to take the advantage of the synergism between anti-angiogenesis and Atrium 90 approach for HCC, which also could be a new adjuvant modality in this setting. And we're actually doing some fancy stuff to characterize the tumor dose and avoid injuring the normal tissue around, using some dosimetry evaluation to focus the radiation on the tumor itself and calculate the dose delivered to the tumor versus the normal liver tissue around it. So moving ahead, let's take a look at other local therapy approaches for those patients with no cirrhosis. So the next one is portal vein embolization and radiotherapy. So Dr. Salim talked a little bit about that, the importance of the future liver remnants. So this is the same study that he discussed. So I'm not going to spend a lot of time here from our institution looking at the portal vein embolization. And the summary of the recommendation was there is no value in normal liver with adequate future liver remnant. So this is moving on to the radiation, and Dr. Christopher Crane is here, so this is a courtesy from his work. So looking at ablative radiation therapy, so this is also very critical, specifically as Dr. Maha mentioned, in settings where if the Y90 is not available, the immunotherapy approaches is not available. So one of the limitations to external beam radiation in this setting is the close proximity to the bowels. So we have an alloder spacer placement approach between Dr. Aloy and Dr. Crane. Dr. Crane just moved to Morris from Caroline, but he's still one of our own. And then that's what you see on the scan. So there is a very nice space, which was virtually nothing. It's about 3 centimeters now, and then you could deliver higher dose using this approach here, and this is how the tumor would look after. And this is another study that also was being conducted with Dr. Cohen and Dr. Crane at our institution, looking into radiation therapy for patients with impaired liver function. So a way to avoid further radiation injury to the liver around it, to look into approaches to isolate the liver from the tumor itself and look at the functional liver and assess the delivery of the dose required that does not lead to liver failure. So this is also a very important strategy. If you have a patient without cirrhosis, you can go for ablative therapy. Even if there is very close bowel, you can have something like a spacer. But if you have a patient with advanced cirrhosis, then the goal shifts to a dose that controls the tumor without leading to liver failure. So that thing here is about molecular profiling. Is this different from patients without cirrhosis? There is mounting evidence from literature about HCC with or without cirrhosis, and they are actually different in terms of molecular profiling here. This is just a snapshot at one of the review articles that looked into that, and you see more TERT and somatic alterations in cirrhosis because it's a chronic inflammatory cascade, while you see very specific mutations and point mutations in patients without cirrhosis. We actually developed a big model at MD Anderson to to study this in a real time kind of thing. So we get biopsies every month almost to detect those molecular changes along the line. So that's in collaboration with our pathologist and our vet team. So let's move now to the left-hand side, which is HCC with cirrhosis. So we talked about how to tailor your therapy in patients without cirrhosis. They go to surgery, so you go for either chemotherapy or local therapy approaches, which could entail either radiotherapy or yttrium-90 or combinations with systemic. So all of that is to reach a goal of making them surgical. So how about patients without cirrhosis? How can we tailor the therapy here? So the first point we have to address is grading of the degree of the liver cirrhosis. As we mentioned, it's an independent factor for survival in this patient population. So if you look at the staging systems for HCC, they were all developed in the 90s, where when most of the patients had cirrhosis and hepatitis. So we looked into that. Our series here, in addition to Memorial Sloan Kettering series, looking at the incidence of cirrhosis and hepatitis in the recent era, and you see a major shift in terms of cirrhosis incidence and hepatitis. And then when you look at the ability of the staging systems to predict survival, it is much better in cases of cirrhosis, because that's where the staging system will develop from, so the same patient population. So we really have to be able to assess the degree of the liver fibrosis very well. So we looked into that in a paper looking at IGF-1 and VEGF to molecularly stratify HCC patients, and then followed it by trying to integrate IGF-1, which is produced mainly by the liver, so we use it as a synthetic biomarker, replacing ascites encephalopathy, and coming up with a new scoring system. And then by doing that, we were able to substratify within each CHI-PU classification 3 different groups. So within CHI-PU-A, you have IGF score A, B, C with different survival outcome and liver reserve status. So we validated that actually from a group of patients from Egypt, and we have 2 more validation cohorts now in submission. Dr. Ashraf is leading one of them from Cairo University. And then we were able to come up with an international study, a biomarker assessment study, to look into the same thing from different patient populations. So this is in collaboration with our MD Anderson sister institutions. So the first step in tailoring therapy for patients with cirrhosis is addressing their status of their liver reserve. And I just alluded to the fact that CHI-PU score is not the best. Within CHI-PU-A class itself, it's very heterogeneous patient population. So the IGF score was just a trial to be able to more accurately assess the status of the liver fibrosis, because it really affects patients not only survival but tolerance to treatment and so on. So after we do this and assess the 2-state disease and looking into the fibrosis grade, let's move on to systemic therapy approaches here and local therapy combinations, of course. So the goal here is prolongation of survival. Another hope is to be able to downsize. So that's why we use local and systemic, as Dr. Salim alluded to, yttrium-90 or radiotherapy to downsize the tumors to be able to take them to transplant. So here we really have to be able to look at the HCC as a risk factor specific disease. So for example, for Hep C, we really have to be able to understand the molecular profiling of Hep C patient population here, and in designing clinical trials, we should look at very specific factors related to the core protein interaction with different VEGF receptors and androgen receptors and others. RAF kinase, for example, was very effective in case of sorafenib, and most of the other drugs did not approach this. We had a common pathway related to VEGF, but not the RAF kinase. So that's one of the theories why sorafenib has been standing because of the effect on the RAF kinase, at least partially, which actually decreases the fibrosis and portal hypertension. So So along the same line, also in patients without hepatitis but steatohepatitis, there are also very specific pathways related to that, and free fatty and oxidative distress and so on. Insulin resistance is a major factor as well. There is, in fact, clinical trials now assessing metformin or statins combined with sorafenib and with other agents for those patients with metabolic syndrome and insulin-resistant pathway. So this is, as I mentioned, the indirect effect of sorafenib on the portal pressure here. A few studies showed this effect that as early as 4 weeks after sorafenib, you see significant decrease in the portal pressure. So this at least partially could explain the survival benefit in sorafenib. And the implications of this would be in future clinical trial design, perhaps combining sorafenib with other agents rather than stopping sorafenib at time of progression. So we looked into also a multidisciplinary approach, tailoring the therapy in patients with hepatitis to see the effect of TACE on the viremia. So you see significant rise of the viral load after TACE. So following that, we had a protocol to treat them with hepatitis C in a clinical trial setting and showed the benefit also clearing the virus before liver transplant and the advantage of that in decreasing the recurrence of the virus. So for those very specific risk factor studies that really have to identify your specific risk factor and look into off-target effects, include viral load in case of hepatitis, include fibrosis grade and portal hypertension. So conducting a tailored study like this in Egypt would require assessment of all of these variables for patients with hep C. So viral load, every restaging and every cycle, fibrosis grade as assessed by radiologic imaging, perhaps elastography, assessed also by the biopsy, the fibrosis grading, and also by molecular markers such as IGF and other markers as we mentioned. So let's move on along the same line of tailoring therapy, systemic therapy, according to this specific patient population. I'm not going to spend time here. We just had a talk about immunotherapy. So I jump to molecular profiling here. The dilemma when it comes to HCC is that the targets that have drugs available in clinic are expressed in a very low rate in HCC, so virtually less than 5%. Those targets that we have drugs in clinic for. The most promising area is the amplification of certain genes. We actually have a study looking into FGF19 amplification with tyrosine kinase inhibitor here. So this is also something that would lead to recognizing the importance of collaboration at the international level, because we're talking here about 5 to 10% of patient population in each of those molecular alterations. So not one center can do this alone. So this is also tailoring the therapy based on the molecular profiling and understanding that you're going to end up with 20, 30 different populations based on the molecular alterations, which highlight the importance of collaboration in those very specific studies. So in HCC, given the fact that it's hard to get biopsies for patients with low platelet count and coagulopathy and so on, so we started to rely on circulating tumor DNA technology. So this is in collaboration with Garden 360 and our Institute of Personalized Cancer Therapy. So there is a concordance between the tissue expression and the circulating tumor DNA expression of about 85%. So it's good enough. The advantage to detecting circulating tumor DNA is that you can follow it serially. So every staging until progression, you can get it, and you can also have an idea about the evolving mutations and the acquired mutations after therapy to design your next tailored study. So we'll move quickly here to incorporating some molecular cytokines in HCC management, focusing on the angiogenesis cascade. Angiopoietin 2 and TIE2 is one of those resistant pathways involved with anti-angiogenesis. So angiopoietin 2 was the only biomarker from plasma that was associated with poor survival in the SHARP study that approved sorafenib. We looked into that in one of our studies was anti-angiogenesis with bevacizumab, and the only marker was the same, angiopoietin 2. So angiopoietin and TIE pathway is really involved with resistance to anti-VEGF. angiogenesis. So combining anti-VEGF and anti-Thai or anti-angiopoietin is really the way to go for this very specific population with high plasma angiopoietin 2. So, and this is actually, just wanted to allude here to the fact that regorafenib is a Thai inhibitor, kind of tyrosine kinase inhibitor. So this may explain why it was the only drug that was successful in second-line setting after sorafenib, because the Thai 2 is involved with resistance to anti-VEGF and anti-angiogenesis. We have another study open at our institution, also we're leading, looking into indoglin combined with sorafenib. So it's also along the same line of combining VEGF with other molecules involved with resistance to VEGF-mediated anti-angiogenesis. So this is just the phase 1 that led to phase 2 and showed some decent data, good signal from a small study. Another area that could also be labeled as tailoring therapy to a specific patient population, building up on the IGF score from our institution and the IGF level reflecting advanced cirrhosis, we looked into growth hormone. So there is lots of negative feedback on the growth hormone when IGF-1 goes low. So growth hormone comes back to the liver, activates the growth hormone receptors, and lead to more proliferation and advanced HCC and metastasis. So addressing that by anti-growth hormone combined with sorafenib, the advantage is there is FDA-approved growth hormone antagonist in clinic. So this is also a personalized, tailored therapy, taking the advantage of patient population with high growth hormone. So we mentioned cytokines such as angiopoietin-2, we mentioned patients with specific molecular alterations, and here we look into patients with high growth hormone and how to tailor therapy to their specific scenario. So it's really critical to understand that for those biomarker studies, we have to be able to standardize the approach, standardize the way of assessing the biomarkers and validate them. So you really have to be able to internally and externally validate your biomarker before suggesting it for clinical use. So there's a national study we have at our institution led by Dr. Hassan, our epidemiologist, looking into 3,000 cases and trying to testing and validation for certain gene alterations. So let's conclude. So tailoring HCC management would really benefit from exploring new tools to assess the hepatic reserve. We talked briefly about our approach with the IGF score, going now into international validation and trying to recruit more centers from Egypt, and also talked about discovery and validation of molecular subclasses of HCC to initiate pre-planned personalized therapy approaches, either based on molecular alteration or certain cytokines, as we discussed. And then tailoring the new agents to specific risk factors is also very critical here. We mentioned briefly about hepatitis C and the last talk about immunotherapy in hep C population combined with hep C drugs. The promise of local and systemic therapy is really critical here, whether it is TACE plus sorafenib or Y90 sorafenib or radiation sorafenib. Dr. Kramer is actually the national lead of a study in the US, stereotactic radiation plus sorafenib versus sorafenib randomized protocol, and we've seen some benefit in this approach as well. Neoadjuvant cytotoxic and local therapy to downsize the tumors in non-cirrhotics is also another approach which I encourage you to pursue for your patients without cirrhosis, because eventually surgery is a curative option in their specific scenario. Thank you so much, and I really enjoyed my time here.
Thank you, Professor Ahmad, for the excellent presentation. Any question for Dr. Ahmad? It is my honor to introduce Professor Osama Hatta, Professor of Radiology at Shams University, talk about intervention.